Okay, good evening. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. My name's Patrick Canavan, I'm the chair, and on my right is Councillor Jackie Edwards, who's the vice chair. So we're going to press on, and I'm going to ask the Democratic Services Officer if she'd be kind enough to read out the housekeeping notice.
Thank you, Chair. Please note that this meeting of the Health and Adult Social Care Overview and Scrutiny Committee is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed exit route and make your way to the surface car park at the front of the annex. Finally, please ensure background noise is kept to a minimum and mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you.
And do we have any apologies?
Yes, we've received apologies for absence from Louise Bates from Health Watch, and Councillor Allen has said that she will be joining, but she may be a bit late.
Thank you very much. And I think we have some colleagues online, and we'll reach you in due course. So thank you for joining us. Are there any substitute members?
No, Chair.
Okay. So any declarations of interest, please? I'll take that as none. Oh, sorry, Councillor Salmon. Oh,
yeah. So I work in the NHS for Dorset Healthcare, member of the Unison Union.
Okay.
Sharon's got some as well.
Thank you.
Yeah,
Councillor
thanks,
Carl
Joe.
Brown.
I think Patrick's got that. Thank you, Joe. Yes, my husband is a non-executive director of the Dorset Integrated Care Board, and I am a support worker to an autistic man who is in receipt of direct payments.
Thank you very much. So we're moving on to the minutes of the last meeting. These were the minutes held on the 5th of June. Is everyone content that we accept those as a correct record? Okay, if that's fine then. The action sheet is attached, and with your agreement, we'll pick that up again when we come to the future planning item later on the agenda. But otherwise, I will just assume that that's okay and in accordance with what was agreed at the meeting. Are there any public issues?
There are no public issues, Chair.
Thank you very much. So we're going to move on to item 6 on the agenda, which is to receive a verbal update from Sam Crowe, Director of Public Health, on the National Suicide Prevention Strategy. Thanks, Sam.
Thank you very much, Chair. Good evening, committee members. I'm sorry I can't be with you in tonight, but I hope that you'll accept this brief verbal update. So committee may be aware that on the 11th of September, there was an update published to the suicide prevention strategy. I'm just going to run through the kind of key points from that strategy, and then I'll update committee on where I think we are in terms of the local work and flag some important next steps. I don't anticipate that this will be a long item, but obviously I'm happy to take questions at the end of it. So I think the main point to note is that the publication on the 11th of September was very much government setting out the refreshed agenda nationally. So a lot of the actions that you'll see in that national strategy are government restating its commitment to the importance of the work that was begun by the previous national strategy. So when you look through the actions, they are very much resting with national government departments. It makes the point that although the suicide rate nationally isn't higher today compared with 2012, which was when the government first launched the national strategy on suicide prevention, they have said that unfortunately rates haven't come down, and there remains some concern about some key risk groups in the population that continue to be affected disproportionately. So in terms of the action for local government and the NHS arising from this refresh of the national strategy, there isn't a huge amount for us to pick up on. We're already well placed in that we've got an integrated care system group which works around suicide prevention and mental health. BCP Council's represented on that group. Public Health Dorset's played an active role in that group for several years now, as has Dorset Council. And we've taken a system approach over the past few years to develop an overarching suicide prevention strategy for the Dorset system. And then within that, we've got separate plans which pick up on some of the actions for individual organisations. So our main mental health provider, Dorset Healthcare, for example, has a separate delivery plan which picks up on some of their actions. BCP Council also had its own suicide prevention plan. And we also work very closely with Dorset Council to make sure that we're continuing to have that focus on training and awareness. What the strategy does say, that was published on the 11th of September, was that we're expecting a refresh in 2024 around the guidance for local strategies. So for now, most of the focus is on national measures, but we would expect that in 2024 there'll be new guidance which will come out and tell us what we ought to be focusing on in terms of our local plans. One of the big changes that's happened since the publication of the first suicide prevention strategy has been better data and more timely data around suspected deaths that are caused by potentially caused by suicide. There's been a big focus by the Office for Health Improvement and Disparities to develop a national data system which is going to provide data within a 3-month period on all suspected deaths by suicide. That's a huge improvement because normally, if you understand the coronial process, any sudden death that might be due to suicide has to go through a coroner's inquest, and that causes considerable delay in terms of the timeliness of local data. So that's going to be a real improvement in terms of how we understand the scale of the issue locally, but more importantly, some of the groups that might be disproportionately affected. We're also supporting some local work on what's called near real-time surveillance for suicides or suspected suicides. And we're going to be holding a regional conference on the 18th of October to look at how far we've been able to progress that work. We've had really, really good engagement with Dorset Police locally in making sure that that local system is up and running and supplying data really, really quickly. The other important strand of work that we've been involved with for several years now is provision of training and awareness. So we run a number of courses to raise awareness around suicide prevention, to make people working in different settings more confident to talk about the issue, particularly if people are starting to disclose issues connected with self-harm, for example, to increase the confidence of practitioners in lots of different settings to know how to handle that conversation and where to go for more support. And then another major advancement in the past couple of years has been the funding that's come down through NHS England to local systems for the provision of timely bereavement support. So that service is really, really crucial. And if I just take a couple of minutes to explain why, in the past 3 or 4 years, we've had 2 suspected clusters of suspected deaths from suicide. These are situations where we've started to pick up patterns where suicides have been linked, either because they are in the same social network or a wider social network that know each other and possibly could have been affected by previous suicides, or because of a common setting. So in BCP Council, a number of years ago, we had a number of deaths that were connected with the railways. And in Dorset Council, more recently, in the past 18 months or so, we've picked up on a cluster which was mainly affecting people from the Weymouth and Portland area who were known to each other. And in those instances, the reason that we are trying to get timely data on suspected deaths is so that we can move very quickly and make sure that bereavement support is offered to that network of affected people, and also that we can offer postvention support to anyone connected with settings like schools or colleges, for example, where there may be further implications from those suspected deaths. So in summary, we are going to work through the implications of the new national plan on the 11th of September. We've already got a public health consultant called Charlotte Pavitt, who's been meeting with NHS Dorset, reinvigorating that system group to look at suicide prevention. But it remains a responsibility of the whole of the system, and that's really my main point for committee tonight as we go through and think about the work moving forwards, having that integrated approach and having all of those partners play a full role in those actions is critical if we're going to maintain some of the good work that we've done so far. So I would expect that when the new guidance comes out in 2024, we will probably move away from having separate plans held by individual organisations, as we've had before by BCP Council, for example, and look at something which is more of an overarching plan held by the integrated care system, but it makes the responsibilities of our local partners really clear. So where public health is concerned, we'll continue to do the work on real-time surveillance. We'll continue to do needs assessments and to do the analysis of some of the groups that are most affected. We'll continue to provide the training and the development to enable people to be more confident in how they talk about the issue, but also support people who might be experiencing impact from suicide. But there will be also more detailed actions for each of our partners, whether that's councils or NHS organisations. So I'm happy to pause there and take questions from committee. But the key message tonight is that the national refresh is very much about restating national commitments. A lot of it is cross-government action. Committee may also be interested that there was some additional funding that came out with that strategy. It's £10 million. It's gone to the voluntary and community sector to support projects or interventions to support communities affected by suicide. That's gone round to our local system, and I believe there are a number of bids that are being prepared working closely with the sector. But for now, we will be waiting until the 2024 refresh of the local guidance and continuing to work on making sure that we've got effective real-time surveillance in place.
Thank you, Sam. Are there any questions on that, Councillor Salmon?
Yeah, I had a couple, so just two really. So first one was on the suicide data. So you talked about improvements in the quality of that data. Just curious, where's that going at the moment, and kind of what does that consist of? Is that part of a mandatory submission, like we've got the SALT for the statutory long-term care? It's the same thing. Is it now of a high enough quality and kind of depth for the DICE are going to be able to link that up to other relevant data sets? And then the second thing you touched on was that you think the innovation that's coming is actually having overarching plans that are held by the integrated care system. Does that mean held by the ICB? And are there any other examples of that where that's already in place? So if you've got someone with, I don't know, care plan for their dementia or whatever, actually that will be held with the ICB or whatever the integrated care system means in this context. Sorry, I hope that makes sense.
Able to answer that, Sam?
Yeah, thank you, Councillor Salmon. Both good questions. I'll take the first one because it's not entirely straightforward. So at the moment, what they call the near real-time surveillance system is a national system that's basically collecting police data on suspected deaths. So these are sudden suspected deaths where it could be a suicide. Now, not all police forces are reporting in with 100% accuracy to that data set, but it's getting better. So that product is going to be used to allow local systems to basically see whether we think that the issue is increasing in importance in a local area. It won't give us the ability to work at a person level with that data. So it's going to be aggregate data only. What we've been trying to do working with Dorset Police is something different, which is using appropriate information governance and security measures to receive notifications of sudden deaths where there's a suspicion that it could be a suicide, and to move quite quickly to make sure that the family, the network of friends have access to timely bereavement support, and particularly where that death might be part of a wider cluster. The challenge is that not all coroners support this way of working. So there is a bit of a split, if I'm being honest. Some coroners are very, very supportive. They understand the need for timely local data. Other coroners take the position that they do not want the coronial process to be altered in any way, and that the full investigation and inquest needs to run its course. So they don't support necessarily talking about this as a suspected suicide because you're prejudging the act. So I'm in discussion at the moment on the Southwest basis to try to change some of the language around this and to talk about sudden deaths and remove the kind of attribution of suicide, if that makes sense. But if we can get the coroners on board and we can get access to timely local data, then we've got a way of being able to work much, much more closely with affected families. We can continue to make those links quite quickly if there are suspected links between the deaths, and of course it means that we can make sure that that bereavement offer is absolutely going out as quickly as possible, and to take local action working with the community where there are things that we can do to mitigate further impacts. So think of the data work as in two flows. There's the national work which is being led by OHID, but that will just really be about surveillance. What we need to do is to make sure that we've got access to that local data, and absolutely if we can do that, then DICE and the Dorset Insights and Intelligence Service provides us with a much, much richer data set where we can understand some of the additional risk factors and links. So hopefully that starts to explain the situation a little bit. The second point about the overarching plans, this is less about an individual care plan for a person and more about the way that we start to work as a system. So integrated care boards are relatively new. We'll be coming to the Integrated Care Board or the Integrated Care Partnership with a new paper talking about the new requirements under the refreshed National Suicide Strategy and asking for a renewed commitment to that system group that's been working already. And we will seek agreement that we're going to, that the system's happy to continue to work in that way, with updated plans for each of the integrated care system organisations. So I'd expect that to come through probably in early 2024. Does that answer your question?
I think for the most part, I just want to check something then. So when you talk about sharing plans, you don't mean individual care plans, you mean more what I would be used to as standard operating procedures. So
yeah, it's a delivery plan. Yeah.
Yeah, so the same thing for whenever anybody says this on the phone line to a healthcare professional, this is what will always happen, this is where they're always signposted. So a uniformity of approach between all of the organisations rather than anything tailored.
Yeah, exactly.
I've got you.
Okay, thank you very much. Any other questions? Yeah.
Thank you, Chair. Yeah. Welcome news about the £10 million funding from government. Do you have any indication on what projects to prevent suicide will receive a portion of this in the BCP area? Thank you.
Yeah, thank you very much for the question. It's a good one. Unfortunately, I don't know yet. The closing date for the submission of bids is the 2nd of October. So I know that locally there's a number of people working quite hard with VCSE partners to get some decent bids in. But until the closing date and the kind of confirmation of funding, I don't know exactly what will be awarded. £10 million sounds like a lot, doesn't it? But you can imagine it's going to every single local area, and I'm sure there'll be hot competition for that type of funding. So as soon as we've got further details, if we've been successful, then of course we will share that with committee.
Thank you very much. Any other questions, please? Okay. The reason why I kind of asked for it to be on the agenda was just to keep the issue under review. So in terms of any further scrutiny, are kind of people content to wait and see what happens in terms of the new national guidance that Sam was referred to in terms of timescales? Is that okay with you, Sam, that we kind of pick it up once that becomes a little bit clearer sometime in the new year, presumably?
Yeah, I think that's absolutely fine. And if the timescales go out, I'll obviously liaise with Louise and we'll find an appropriate agenda slot. But I think it's best done in stages. So first of all, we will reaffirm the commitment from the integrated care system to keep the work high profile and to keep it high on the agenda in terms of its importance. And then once we've taken that paper through the system, I think that would be a good time to come back to committee and share details of how we're going to refresh the local action plans, because that's the important thing.
Okay, thank you very much.
Just very quickly on that, can I just clarify, is that a DH national plan from 24 or is that an NHSE?
So the strategy refresh that's just come out on the 11th of September is cross-government. So it contains a number of commitments from the Office for Health Improvement and Disparities, which is part of Department of Health and Social Care, but it also talks about the importance of having other government departments involved, like Ministry of Justice. It makes the point that a lot of the risk factors around suicide are connected with other parts of government business. So there's a big focus in there on effective drug and alcohol treatment. It talks about reducing the harms from gambling, for example. So that first strategy refresh is sort of setting up the issue as a cross-government challenge. When it comes down to the detail of how integrated care systems will be working, that would really be a focus for NHS England, asking systems for what their response is. Some of the funding flows down through NHS England, but it remains a broad responsibility, so it can't just be framed as a health issue, if that makes sense.
Okay, thank you very much. So can we move on then to item 7, access to GP practices in the BCP area? And I think we've got Alan Young and Rob Payne from NHS Dorset. We've also got Kate Calvert here from NHS Dorset as well. So I'm handing over to you. Thank you.
Thank you, Chair. So we'll take the paper as read, a short presentation just to take you through, which we thought might support the discussion on the paper. And the first, if we could just, I thought it would be important just to put a bit of context around the discussion in terms of access to general practice. It is a key area of focus for us in the ICB. We know we've got huge variation across Dorset. There's a number of factors that influence and impact on access. And some of the key challenges that we've identified are really about, we've got, I think, 70 at the moment, general practices. And of course, they're all businesses in their own right and therefore have their own operating model. So how they run their business is within their gift, as long as they deliver against their NHS contract. So that's one of the challenges. The increasing demand and challenged workforce. We've had lots of conversations, particularly over the last 12 months, about the sustainability of general practice across Dorset. So both in BCP and Dorset Council areas. Since COVID, we talked about, access. It became a national topic of conversation, particularly around seeing face to face. We actually increased demand by going to a virtual model of consultation. So we actually opened up access. So a lot of people were contacting general practice because they could go online to do it. And that put increasing pressure on some of the practices to actually manage some of that. So it's been quite difficult to find the right balance in terms of how do we actually see the people that need to be seen, which is really the next challenge that we have, is actually about public expectation and about clinical need. So it's really difficult to try and balance out and to understand, okay, so how do we get access right? What does the model look like that will best meet the needs? So to make sure that we see the people that really need to be seen, both either on the day or within a reasonable time. We do have we have a national driver around this. We've got some targets around access for seeing people for a routine appointment. The challenge we've got around that is the data. So we know that we don't always count things consistently across Dorset, across the country actually, in terms of how we code consultations. So we've got some information there, but we know that we've got challenges around that we're working through. And Alan's going to just take you through some of the more detailed data. And what's really important, and what our practice staff tell us, is what's invisible that they don't count. So all the additional work that they do to support providing services for our public. So there's something that's hidden there that we have to do a piece of work around, I think, to really understand what's going on so that we can make sure that we reduce the variation we've got. And actually, we are providing good services for our population. But I'll hand over to Alan. Just take you through the detail.
Thank you, Kate. So general practice appointments are rising year on year, and this is reflected across the BCP area, Dorset as a whole as well, and nationally. To give you a bit of further context, appointment activity through BCP has risen by over 14% since May last year. In comparison to the national data, our practices provide on average 10% more appointments per 1,000 population than the national average. Whilst obviously we're very proud of this, and it is a testament to the amazing clinical teams within BCP, it is important to emphasise that the well-being of our team and safe working levels are consistently advocated for. In October 2022, enhanced access was implemented across BCP, requiring each PCN to offer appointments on Monday to Friday between 6:30 in the evening and 8 p.m. in the evening, in addition to their core hours, whilst also delivering services from 9 till 5 on a Saturday as well. To support the delivery of enhanced access and to continue to meet the needs within core hours, the BCP PCNs have also been utilising the additional roles reimbursement scheme, which has provided an additional 168 whole-time equivalents into the BCP area since 2019. When considering access into general practice, as Kate mentioned, a central target has been set, with the expectation that a routine wait time should be under 14 days. In August 2023, BCP average routine wait time is 13.7 days, and throughout the previous 12 months, BCP area has not surpassed the 14-day threshold. However, despite increasing appointment activity significantly and continuing to be above the national average for appointments per population, BCP practices are moving closer to this 14-day threshold, and it's clear that a continual increase in appointment capacity and workforce is not the long-term solution to controlling this wait time. Therefore, a variety of national programmes have been released to support general practice in its effort to battle against rising demand. In May 2023, the delivery plan for recovering access was released by NHS England. The document, better known as the Access Recovery Plan, is an umbrella document which highlights a vast array of primary care improvement programmes that are on offer. The Access Recovery Plan has 4 aims: to empower patients, to implement a model of modern general practice, to build capacity, and to cut bureaucracy. The modern model of general practice will see the adoption of cloud-based telephony systems and better integrated digital apps that with a focus on the NHS app. At present, across BCP, there are 11 practices that need to transition from analogue phone systems to a cloud-based system, and funding has been provided to support this transition via the Access Recovery Plan. There are numerous benefits to a cloud-based telephony system, but the main ones include improving user experience through automated routing of calls and therefore a reduction in phone waiting times. The systems also empower practices with better data to inform their strategic approach to demand and capacity. So with the adoption of new technology driving many transformation projects via Access Recovery, the plan also sets out training and support pathways for a variety of clinical and non-clinical roles to support the transition. Care navigators who triage patients' access requests into general practice are being offered support under this plan, with NHS England expecting the majority of PCNs to take up this offer. The ICB has worked closely with practices to ensure that they can access this when they're ready, and we've already seen over 50% of practices sign up to the support at the first time of asking. Similarly, the new role known as the Digital and Transformational Leads, employed at PCN level via the ARS or Additional Roles scheme, are employed to consider both digital transformation and overall transformation, are also supported by the Access Recovery training programmes. The development of the care navigators and the digital and transformation leads aims to strengthen the resilience and experience within general practice, aiming at better managing current capacity and future-proofing capacity plans. The Access to Recovery Plan also advocates for the continued use of the community pharmacy clinical service and for a focus on increased self-referrals over 7 different clinical areas. and they are community musculoskeletal physiotherapy, audiology, weight management, community podiatry, wheelchair services, community equipment services, and full services. So considering the breadth of the Access Recovery Plan and acknowledging the pressured environment of which general practice finds itself in at the moment, NHS England, with support from the ICB, are providing practice with hands-on support known as the Support Level Framework. There are 3 access routes to this support, which are dependent upon their own need. The first is a universal offering available as a self-service tool. The second being an intermediate 3-month offer, and the third being an intense 6-month program. The structures are reflective in nature and therefore are designed to support practices' own needs. So in summary, the short to medium term future for improving access through BCP will be working through the requirements set out in the delivery for recovering access. As you will have seen in the paper, the separate PCN access improvement plan will also make up part of this journey, focusing more on the wants and needs of the population. It's important to recognise that whilst digital development is key, the needs of the population must be considered. I'll pass you back to my colleague Kate, who will briefly discuss the longer term approach to access in the ICB.
I think sorry. And we picked up on this, I think, briefly when Sam talked about having single ICB organisational plan. There's a lot of work that we appreciate we need to do in that community, in our community, working with providers. And we've just commissioned, earlier this year, we commissioned the National Association of Primary Care to come and do a piece of work with us to look at how we could develop our integrated neighbourhoods, particularly around teams. And actually, how do you strengthen the resilience of general practice? But actually, how do we make sure that we deliver services locally that best meet the need? And how do we get the right professional and workforce in place to do that? So part of that longer term strategy is wider than just about access to general practice. It's actually access to it is really about the right person, right care, right time, right place. And that's what we're trying to invest in. So when I talk to my general practice colleagues, I have said to them, I don't want to put more money into general practice. I want to invest in integrated neighbourhoods and communities because I think that will make a difference. And that's not just within health. There's an element of work that we need to do around integration within health services. But it is that wider agenda. It's about how do we integrate with our partners. So it's not just about health and care integration. It's also about the voluntary sector. It's about other services that actually, and working alongside our community to do things in a different way. So it's a big cultural shift that we're looking forward to. But actually, if we don't start now, then we can keep on monitoring access and we can have all those plans in place. But actually, how will we know that it's really making a difference? And how do we really make sure we don't have the variation that we've currently got? And the postcode lottery of depending where someone lives will depend on what your experience is like. So there's a lot of work that we do want to take forward that actually builds on the access program that we've got in place with general practice. So happy to take any questions.
Any questions? Councillor Carr-Brown.
Inevitably. I just had a couple towards the end. You talk about the funding through the capacity and access improvement payment, and that 70% of it is automatic and 30% is based on performance. The NHS has a nasty habit, or the Department of Health has a nasty habit of giving people more money if they do well. Is that the case with this, and how are our PCNs doing?
Yeah, thank you for the question. So there's a 30% remaining through the capacity and access improvement payment that we will be looking at. I think it's the 31st of March until the 1st of August, in which case, the time period in which it gets given. Our intention is to have PCN business managers present to the ICB to demonstrate their journey through access from the start of the improvement programme to that date. We're not looking at setting targets. We're not looking at setting a position or a line in the sand where they need to be. We're looking at more their journey and their aspirations in line with the aims of access improvement. So it's difficult to say where we would like them to be or where we expect them to be because it's their own bespoke journeys. And when we say we'll judge them upon that, but that's the conversation that we expect the PCNs to be bringing us.
Okay, any other questions?
I do have one.
Could you put your mic?
Oh, sorry. I've got one, but I think somebody beat me to it on Teams.
Okay. So I can't see your hand, so my apologies. Do you want to ask your question?
Hi. Hi, sorry, Chair, was it you asking me? I wasn't quite sure. I didn't quite catch that.
I can't hear that.
Yes.
Yeah, that's fine. No, thank you. Firstly, I'm sorry I can't be with you tonight. I've actually got the lurgy myself, so it's probably very apt with a health and social care meeting. I just really wanted to clarify a point regarding the 14-day access to the to GP for residents. Does that, the 14 days, does that include online, phone access, or is it face to face? Is there any criteria? Because I'm just kind of wondering how people we work out. I appreciate it's done on an individual sort of basis, but I'm just thinking from a sort of a resident's patient point of view. If you get what sort of criteria is kind of used for that, and if people wanted a face to face appointment, they'd have to wait longer than the 14 days. So that's what I wanted to ask, really. But thank you.
I hope you heard the question because I didn't hear it. I can't hear it.
Yes, no, thank you, Chris, for the question. Yes, to answer. So the 13.7-day routine wait time includes all appointments, and that's kind of where the data issue sits as well, because not only does it include all appointments, it includes the appointments when people choose to wait longer, or that there is a clinical need for them to wait longer as well. For example, routine diabetes checkups every 6 months to 12 months or so, where they'll stand against that target. So there are some concerns, but yes, to answer your question, it will be against all appointments.
Councillor Salmon.
Yeah, so I've got a question more on the methodology of the report you've presented us with, and I don't want to come across as overly negative, because I can see a lot of work has got into the report that's been presented to us, and there are a lot of insights I think we can pull from it. But I am worried about our over reliance on this format of report, because I think the data, once it gets to a report like this is where data goes to die, and so there are some nitpicky things I could say about the way the graphs are a bit small, like what's this, a table for ants, but more so that we need to be able to be slicing that data up, I think. So for example, Sharon had a question about the cost and the spending and so forth, and I assume there would be a way to chop that up and go, oh, actually this month this was how much money was spent, by the various PCNs given to the surgeries, however the waterfalling of money comes through, how many appointments were made and so forth. And I'm worried that if this is how we're going to scrutinize an area of health, that we're not going to be getting the whole picture. So we really need this to be presented to us in a way that we can slice this up. This should be interactive. This should be something in Power BI, Tableau, or something like that. And I just wondered if that was something that in future would be possible for how we would have this data presented to us, because I don't think I could hand on heart say, and it's not a criticism of the quality of the work that's gone into the report, but that I feel like I can properly scrutinise the access to services. Like, I'd want to see calls data, and it sounds like that's something that will come with the move to the cloud-based system, where you'll actually be able to see, look, this isn't just the number of appointments that were given once there was a need for an appointment identified, because I think, like you say, there'll be data quality issues. Most people will phone up, ask for an appointment, be told they can't ask for an appointment, and then phone up the next day if they need a same day appointment. And I bet you that first contact isn't included in this data, you know, without a doubt. That's not how it's collected and processed, I would imagine. So there are those oversights. But yeah, PDF reports are where data goes to die, you know, and it's going to be really hard for us to scrutinize with this kind of data, with this kind of report coming to us. I think it's going to be really hard for David to be making informed decisions as with his post in the cabinet, you know, all his responsibilities, and it's going to be hard for the leadership in the ICBM. I want to see this in a more interactive format, and I wondered if there were barriers to it being presented in that way, or if in the future that's how it could be presented to us.
I think that's a good question, actually, and it's always hard to know, you know, this new committee access, how do we best present the information? So we're happy to take that away, because equally we do have some of this information in terms of Power BI, we can break it down. So we're happy to take that away and look at how we can provide a bit more detail in terms of, so that it is right, it's Scrutiny Committee on access.
Because am I right in thinking some of those graphs are screenshots of Power BIs that you've whacked in? That's exactly what's happened. Oh, wouldn't it be lovely if we'd had the links to those weeks before? I mean, it'd be awful for you. I'd hit you up with far more questions, but that would be the promised land, wouldn't it?
I think you're quite right. We know we've got data issues around, and that's probably why sometimes, you know what it's like, as soon as you put data out there, people hold you to it because they think that it's right. So but it's the balance. But what I never want to lose sight of, and that's why I did the context, is actually it's what you don't see in the numbers. So as much as the quantitative numbers and information is important, it's also that qualitative side, isn't it? It is about the patient experience. We know the friends and family test doesn't really work for general practice. We know we've got variation, and we have to dig a bit deeper in terms of that. And it's the how do we do that in the right way that's supportive of general practice, because they are under huge pressure for some of them. But it's not equally one and the same. So with practices, there's a general message, general practice is under huge pressure, and we've got sustainability. Actually, I'm interested from our perspective is, what does that look like? I'm a bit like you in terms of the detail. I want to know, well, I know that that's not the whole picture. It's not like that for every practice. Some practices can have no issues recruiting. Others really struggle. And I guess my benchmark or my stick is when I hear those practices that don't usually have issues recruiting, when I hear that they're struggling, then I know we've got a challenge. So GP workforce at the moment is really difficult. I look at the graphs, and since 2015, since we've been recording, you know, that's a downward. It went up and then it's gone down. And we need GPs. They have a role to play. So even though we're investing in additional roles and workforce, they're at a primary care network level, so a bigger scale. That's not going to replace the challenge we've got at practice level. So if we've got a practice that has got, you know, gets down to one GP partner, that we're in trouble. We know we're in trouble. And that really leads us, I think, into, which is why you've got a couple of papers around mergers and a practice closure. So you're quite right. We'll go away and think about how do we present the information around the access, so you know what we're doing and what does it look like. But equally, I think it's the qualitative side, and I don't want us to lose track of that context, if that's okay.
Thank you. Councillor Edwards had a question.
Yes, thank you, Chair. I've got a couple of questions, actually. I just wanted to ask about this additional roles reimbursement scheme. If you could just expand a little bit more on that. Are you talking about recruiting more people in that scheme, or is it just sort of like the equipment, like you were saying, the ones that to use the cloud system and that? And if the funding is ended in March 2024, what does that mean for the GP surgery? Is that going to be an extra financial burden on them? And they may say, can't afford those extra people, and they disappear, and then you're back to sort of square one. And then if I can ask a second question after that, if that's okay.
Of course, no, thank you for the question. So the additional roles, when it was first released in 2019, I think there were 5 clinical roles, of which I think there was an advanced nurse practitioner, advanced physiotherapist, and a couple more. It's now up to 17 clinical roles. Actually, within that, there are a few non-clinical roles as well. They are employed at PCN level, so most of the time a PCN will employ an R's funded individual and then place them either at a practice or they will work across multiple practices. And with regards to their funding, although it ends in March, there is an expectation, although it isn't published just yet, but there is an expectation that the funding will continue. It may just be in a different guise. But the practices and PCNs have been assured that the funding should not be going anywhere and that they should be able to continue to employ these people.
And can I then ask about under the sort of risk for BCP, because we do have generally an older demographic sort of population, plus we have a huge influx of students and tourists in the summer that can fall ill. We've got a growing population. We're also housing refugees. So with all this sort of happening, are there any plans to build more GP surgeries or more medical hubs to sort of deal with all these these extra people, the extra demand on the doctors, the GPs, dentists, everybody to do with their health, sort of in the BCP area?
And in terms of, so our requirement is the ICB, we have a responsibility to ensure that everybody has access to general practice. So, you know, that's our responsibility. In terms of some of the conversations is understanding actually and we talk about a ratio of what's a safe number per like general practice practitioner that actually can safely support a population. So we always look at that. I think that's the challenge around the demand, and some of the work we need to do is to better understand that. Because actually it's really difficult to square the circle at the moment. We've got increased demand, got decreased workforce, and actually what does that mean in terms of the risk of patient harm? Who aren't we seeing? Or with so many people coming through and wanting to be seen, how do we know that, you know, we're seeing the right people necessarily? There's all that we need to be able to understand and to look at. In terms of the model in the future, this is where I said before, I don't really want to necessarily invest more in general practice. I want us to think about how do we work collectively and locally at a neighbourhood level, thinking about our general practice and community resource from a health perspective, to think about what is it that we need that's best going to meet the need of that group. So understanding where we've got an older population, what would that team or that expertise and skill set that we would need to have in that team? Because the challenge with the R's roles, so NHSE said, yes, we're going to invest in general practice, more workforce, quite prescriptive about what you could take on. But it wasn't, so people went out and recruited, but they didn't have that conversation about actually what is there, or look at the data to understand what's the need of their population. Because actually you could go and pick off this list of who you would recruit, but would they be the right person that would really make a difference for that population? Because actually for an older population, maybe we want stronger geriatrician input, for example. And that's why it's really important that we don't just look at the general practice workforce and what they do in isolation of that wider system. The more that we can understand the needs and the local population and the demographic, I think we've got a better chance then of actually maybe improving, you know, outcomes and actually having the right workforce and resource in the right area. So it's not necessarily about more general practice. It's actually having the right services and, you know, the skill set and capability in the right area. So that's why the integrated neighbourhood work that we're looking at doing is so important for us.
Sorry, can I just ask then, is that would you be using, we hear in the media about pharmacists being asked to do some of this work as well? Is that what you'd consider, that the pharmacist could take on some appointments? But I don't know what they do at the moment. They may be doing the COVID jabs, or they may be doing the flu jabs. I don't know, but to take off some of the pressure off the surgeries. So would you involve pharmacies with that?
Yeah, definitely. And the national contract, because pharmacists also have a national contract, and they're actually being commissioned to do a little bit more. So they might pick up minor illness. So actually, if someone comes to a GP, we've got a scheme in place that actually they could refer on to the pharmacist. There's still a bit of work to do because, of course, and we know we've got a huge challenge around our pharmacist workforce. So yes, definitely, when we talk about that wider model, it's about understanding the wider skill set that we need.
Councillor Cabaret.
So just coming off what you were just talking about, the thing that really came to mind was, and it's not strictly speaking in here, was what the ICB, or what is happening around social prescribing, because it seems to me that that's a really promising channel of community work, as it were. A lot of it can be quite community based. And so I just wondered, where are we with that? How are we doing with social prescribing? Is that something that PCNs are embracing? Are we having trouble with it? That kind of thing.
Yeah, it's a good question. We do have the so the social prescribers are funded through the R's role, and the PCNs will submit their R's allocations through the portal each month. So we do have the data. I don't have the data on me, unfortunately, so I wouldn't be able to say. But anecdotal feedback is I do know that they are well used across Dorset, especially through their access improvement plans. They were advocating for their use, so it's certainly part of the plan.
I do know that because social prescribers, that's where we started with the R's roles, and funding came through for social prescribers. And then actually, I think practices and PCNs realised the benefit of what a social prescriber having a social prescriber in their practice could do. So what we saw was actually, out of the list of roles that PCNs, because it is up to them to choose who they want to employ, we actually did see an increase in the number of social prescribers that they wanted to take on. We also have just recently commissioned a service around Dorset self-management, which is about non-clinical health coaching, and also some additional sort of social prescribing in that specialist area. So it's definitely an area that we need to look at. In terms of particularly around the outcomes, what difference they're making. And it's not just social prescribers that we might recruit through health. There's also that wider link in terms of, and how social prescribers are connected, particularly to the voluntary sector. And it's that signposting, isn't it? So knowing actually, if you don't have a health need, but really need some support, then that's where the benefit of having that social prescribing model within health.
Something. Yeah, I just think it's really worth noting that Kate set some context in the direction of travel as well, and I think it's important to think about. We've had 70 years of general practice. It's been a very medical model, and I don't mean that in a negative sense at all. But I think we're starting to see a bit of a culture change about the connection between general practice and their local community, about the wider determinants of health and the role of that more skill mixed team working with their community. So I think this is a really good thing, but I think we need to recognise that we're just starting out on that journey as well. Okay, I think Councillor Farr had another question, then I'll come to Councillor Edwards.
Thank you, Chairman. You mentioned people living longer. Recently, I met with a lady called Sue Waugh from Prima Life, who provide invaluable service of regular events such as lunch clubs for the elderly and sort of support groups for those who care for those with dementia. These people might otherwise be alone and struggling, and the people that are isolated, and life can be harder. I think it's what you mentioned, the community, perhaps a community resource. I just wondered if you might be working alongside organisations such as Prama, Life in the Community, or others that I'm less aware of. Thank you.
Thank you. Actually, I met with Sue just last week because I attended Health Watch to try and explain the ICB, which actually sounds simple, but I tell you, a lot more difficult than you'd think. And I did a follow-up. I wanted to have a follow-up because I was talking about the integrated neighbourhood work, and she was sharing some of what she was talking about, and kind of that, been here, done that, let's not go off and let's build on what we've got. And I had a really interesting conversation and thought, oh my goodness, this is what we don't know and what we're not connecting. So the more that we can actually have those conversations, and I'd love to go, she talked to me about their 10-week dementia course, which sounded amazing. And I thought, this is what we need to do. This is what probably really makes a difference. And that's what we've got to connect in. So as part of our model, and as a commissioner within NHS Dorset, that's our challenge. I think collectively, though, as a system, is how do we invest in more of that and less of what we're currently doing? Because this is a big shift, though. You know, we do have general practice. It is a medical model. We need general practice. But what do they do versus what do others, our other partners, do in the system? So definitely started the conversation. There's a lot more that we need to do.
Thank you. You just mentioned the integrated care board there. I just wondered, has it had, and what's the impact so far on the general practices? Has it had an impact yet, or not?
In terms of impact, what do you mean?
Well, how are they working with it? Are they finding it okay? Does it help them? Is it more technology that's they're helping them with, or is it actually helping general practice?
So, of course, we were a clinical commissioning organisation that was GP led, and it was quite a transition. And our practices were really worried when we moved into the ICB that actually they'd lose their voice. So we've actually supported them to establish the Dorset General Practice Alliance to actually enable them to still sit around our table and be involved in the conversations. So we invested in the first year of establishment for that, so to make sure that we'd still work with them. Now, actually, if I'm going to be honest, it's difficult because, of course, we've come from GPs have been used to working in a model that they've been involved in the decision making, and they were the commissioners, and actually they're now a provider but equal partner. But it is a transition because actually there's a different conversation that they need to have with us, and we need to have with them, but all partners because they're a partner in the system. So we still support them. So we haven't stepped back from the level of support that we provide them. But it's a different way of working, I'd say. So if I'm going to be honest, it's a work in progress. And I think that would be fair to say across the whole ICB, we're still a work in progress. Does that answer your question? Thank you.
Thank you. Are there any other questions? Because if not, I'm going to ask, well, you're waving your hands at me, Councillor Brown. Or okay. Just in terms of the primary care network and the access to improvement plans, which you had the deadline of the 30th of June on. I'm assuming you've got those now from the primary care network. So my question really is, are these documents publicly available?
Yeah, good question. I don't think that they're publicly available because effectively they are PCN business plans, and obviously they are their own private entities. However, obviously we can share with you that all 18 PCNs across Dorset had their plans signed off by the ICB, and we presented one plan to NHS England, which was then we received feedback last week, and it was supported as well. So we're very confident that the plans that they submitted are in line with the aims of access improvement and should therefore meet the needs of their communities.
That's a very good question, actually, isn't it? Because it's public funding and we need to be accountable for that. So I think that is something that we just need to take away in terms of should they be, because that's what I'm asking, you know, should they be actually open? Should they be shared? And it might be that we share a summary, but I think that's a good question for us to take away and consider.
Thank you very much for that. Any other questions? Okay, well, there's a considerable amount in all that, so thank you very much indeed for presenting that. In terms of areas for further scrutiny, I'm just wondering whether we put the item on the future programme meeting and look to see if there are bits of that which we would need to unpick or delve a little bit further on, rather than try to do it here. Does that sound like a reasonable way forward? It might not be any, but certainly optimistically, but that, you know, there may be specific aspects of the work that you've just outlined that the committee might be interested in getting a little bit more detail about. Is that okay?
Yeah, that's fine. And I think it would be really good for us to, if we could bring and just share with you the integrated neighbourhood teamwork that we're doing, because that will equally provide some of the context that I've spoken about tonight, if you'd be interested in that.
That would be really helpful. Thank you very much indeed. Somebody's not quite so sure, but there you go. Okay, then we're going to move on to item 8 on the agenda, which is the closure of the Winton Healthcare Centre. And again, we're handing over to colleagues from NHS Dorset to run us through that. Thank you.
Okay, yeah, thank you, Chair. And we've got a couple of colleagues online as well, if there's any technical questions, because the colleagues online were the ones that are actually leading the process out in the field, as it were. So I'm just giving you an overview. So Chair, I'll take as you've received the report, so I'll take it as read. But I just wanted to just highlight a few points, if I may, before we open for any questions in relation to it. So committee members will be aware that a report came to this committee back in May, which we then agreed to update the committee on the outcomes of this piece of work. And you'll note from those previous discussions that we had a receipt of a termination of contract letter from the Winton Health Centre, and we looked at options to find alternative provision. And in the end, despite all attempts, including the extension of the contract at the time, we led to having to go to what's called a managed list dispersal. But that's very much working with general practice to manage needs locally and engaging patients in that process. So that was what was described at the last committee. So really, what I'm doing this time really is confirming the outcomes of that piece of work. So I'm pleased to confirm that all patients have been successfully supported to find alternative general practices in their local area, in the Winton area. And as part of that process, we also support all the vulnerable patients to make sure they've received additional support. And that particularly provides support for them in terms of making sure there's continuity of care, so that reduces the anxiety of the patients and also their carers as well as part of that process. And you'll note from the paper as well that there are a few of those patients that were kept on by those the original practice as being out of area. So as part of this process as well, we've been in touch with all those patients as well, advising of the closing of the practice and encouraging them to re-register with a practice closer to their home as well. So a good outcome overall, a challenging process, but as you heard from colleagues earlier as well, we have to do this work together with general practices, other providers in the area, and we have to work with the patients really importantly as well to try to make sure that we get the best possible outcome for patients and make sure that our duty about making sure that every patient has access to general practice in their local area is achieved, and we can confirm that was achieved. You'll also see in the paper that we refer to primary care network changes. So we've taken the opportunity as a result of discussions with practice in the local area that the Denmark Road surgery wanted to join the South Coast Medical Group, and what that actually does is it better aligns the practices in that local geography to be working together. So that's been part of the change to realign the primary care network. But we do also note as well that the Westbourne practice now becomes what we refer to as a single practice primary care network. It is a large practice and it provides care over a large area there with, you know, quite a large workforce as well. So and they are content at the moment that that is a sustainable model for provision in that local area, but we're still open to working with them and other practices and partners in that local area to look at the provision in the Westbourne area moving forward to make sure that continues to be maintain good access and sustainable model of services for that area. So that's what I was going to sort of summarise, Chair, in terms of the updates from the previous paper, and happy to take any questions. Thank you.
Okay, okay, and thank you very much. I'm very aware that there's a wee bit of a time lapse in this process, but I did ask for it to go on the agenda only out of my ignorance, really, just to better understand the process that had gone through. So, are there any questions? Councillor Giddett.
Just in terms of the numbers, I actually attended the meeting that the general practitioners put together for the patients back in May when they were announcing the changes. And actually, it does impact. You say Waterstown and Winton West and Winton East. It's opposite the border of Talbot Woods Ward as well. But there were a couple of things which I think they would probably feedback. First of all, the maps which were provided, the location of Denmark Road practice was actually appeared to be in Charminster Road, and a number of patients, people thought that's where it was going to be, even though it was called the Denmark Road practice. The other thing as well is that patients were advised if they wanted to change their allocated practice, they should wait a whole calendar month. And although you said that there were 55 inquiries, there are quite a few people in that room who actually are waited until, obviously it's shut on the 31st of July. I've been told to wait until the beginning of September before they moved. I'm surprised actually there were 55 that moved, given what was the way that they were told it was going to work within the context of that meeting. Is there going to be any sort of follow up in that, in terms of who moves across? Because I think particularly the Shelley Manor, a lot of people thought that was too far away and they weren't able to get to that. Is there going to be any sort of follow up in respect of whether people do have access to those surgeries?
Yeah, really good question. Thank you. First of all, I can only apologise if there was an error on the maps. I wasn't aware of that error, but we can go back and look at why that was the case. In terms of working with other practice, I think it's really important to say that we did do a lot of work around the mapping exercise to understand where patients, their postcodes were, and location to various practices, and then we use that to inform a conversation with those practices around their ability to take on patients. So obviously we were trying to reflect a lot of the conversation we've had tonight, really, about we make sure that patients are able to access a general practice in their local area, but we try to do it in such a way that we don't actually destabilise the general practices that they're going to, because obviously that they then have a future knock-on effect about sustainability as well. In terms of feedback there, I think we can take that away and look at that in terms of what the feedback is from patients on that. I think probably just a couple of points I'd make. We're aware of, and I think it's reflected in the previous paper, was around managing the communications around this is quite difficult, and patients, did hear earlier than officially in some cases, and some patients chose to move early on. There is a complexity around how you best manage the process in terms of not only that continuity of care, but also setting up those practices to receive that number of patients. So that's a significant number, obviously, of patients to those individual practices. So that's why we keep that delay to a minimum, but there is some process stuff that we have to work through to support those practices to be able to build up their capacity and arrangements and their changes in their business and their care model in order to take those patients on. So I take the point that we can take that back and look at some of the learning from that, but there will always be a bit of a lag time between that initial process there and actually full implementation and ensuring all patients are able to move across into those practices.
Okay. Got a follow up, Councillor Gillett?
So if we can just find out how many patients have moved since September, that would be great, because that was with the thing which they were told was the time when they were told to move. There was one other real short follow up as well, and that was that I was told by the GPs that you were allocating funds for the initial for the initial move for the patients to be moved across to the new surgeries, but then going forward they were going to use 2 surnames and a formula for the name of in terms of how they thought that people would be okay to begin with. Those practices might be okay to begin with, but there might be an issue in the future because of the formula which you use, and they didn't find that they were able to make enough money off those patients. If that makes sense.
I think picking up weighted capitation probably is the phrase you may or may not have heard, but it's a way in which we try to allocate funding according to the population need of that practice. I think it's fair to say there are some challenges to general practice when there is particularly a shift of a large number of patients, because it does have an impact on the way in which they manage their business. So what we do alongside that is try to understand the impact on their businesses, and we look to provide what we call some resilient support. So effectively some non-recurrent funding and support in the first year of that move, because recognizing that that business change comes with costs. So we do support the practices in those areas as part of that first year, because we know that's a particular challenge as part of that process.
Okay, thank you. Councillor Carr-Brown.
Similar question, not just about the sort of patient satisfaction over the transfer, but ongoing patient satisfaction. Is any work being done on that? I mean, I'm thinking particularly like Denmark Road, they've had quite an influx. I mean, it would be interesting to know how that is actually going. Are they able to see the doctors that they want to see? Is there enough capacity within Denmark Road to actually cope? You know, how is it, what's in 6 months' time, if you like, is any work being done to see how that settling in has gone?
Yeah, really good question again. I think there's probably 2 main areas. One is the work of the patient participation groups, which were part of the process of engagement as well, but understanding from their perspective how they think it's worked. And then we've got perhaps a more sort of, I suppose, objective measure in terms of the patient satisfaction surveys that are carried out annually. So we can actually review that and find out the impact of that. I think anecdotally, working with the practices, it is a real challenge in the first year, I think, of managing the need there. So it's very much that partnership with their patients about understanding that there is going to be some impact, and how do they manage that together as well. So, because I think there's some honest conversations, with the patient groups about, look, we think this is best, this is going to be good for the future of the practice, building up the practice list, good for the future of healthcare in the local area, because it's trying to stabilise the practice provision. That's what we don't want, as I explained, and my previous answer was about, we don't want to destabilise other practices in the area, because we'll just end up with a cyclical effect on this as well. But it's a good question, and we can review that further.
I would be interested in that review, because the surgery in my ward in Leybourne Avenue, of course, shut down not all that long ago, and patients were transferred to Winton Health. So they're there for about a year or so, and then they're sort of moved on again. So I think that it's sort of not really very fair on those patients that they've had to go through this twice, and they're not actually that close now to an actual doctor's surgery. And I think, yes, I think I would certainly like to see a review of how the patients felt about being shifted twice in only a few years.
That's a really good point, and I think actually the Leybourne patients have been particularly unfortunate about this, because I in the 30+ years that I've been doing this, I've not come across that sort of double change going on. So I think probably reflects a lot about the resilience of general practice in that area, and a lot of GP practices struggling in that area, which is why we were so keen to work with the practices about finding a solution. But yeah, we do need to look at that.
Councillor Salmon.
Just following up on what's been asked already about the kind of movement of patients and whatnot from the surgery. One thing that's not identified as a risk is the capacity of the other surgeries, or forgive me, I might have missed it, but that is not seen as something that could be a problem. There isn't capacity within the other surgeries to deal with the number of patients they're going to have to take on, which is lovely and reassuring. What I would want to see though, and again, I think this is a problem of the methodology and the expectation of what this committee would like to see, normally may have seen in the past. But what I'd like to really see is what's our forecast? In 5 years' time, will those same surgeries still be able to serve that geographic population with the increasing demand we're likely to see with an aging population and a growing population and all of that? And I feel that's something that needs to be in here. The other thing that potentially is out of scope of this is for actually the closure of that surgery probably could have been forecast long ago, could have been forecast when the premises no longer became viable for that practice. As far as they were concerned, they couldn't have the number of patients for that building that would make paying the rent of that building viable. So they were always going to close. There was a point almost at which you could go, right, that's it for Winton, probably definitely going to close in the next few years. And so they did. And I just wonder if there are any other surgeries that maybe need to be on our radar as actually this is a potentially at-risk surgery. With this economic model that they're being required to operate in, actually we don't think they're going to be viable in 2 or 3 years' time. And I'd like to know that, yeah, I feel like that is something that needs to be in our pre-analytic vision. And I guess the second part is out of scope. What other surgeries potentially are going to go put. Certainly the forecasting on demand, I'd have liked to have seen a bit of that. And I don't know if that's something that has been considered.
Thanks. Again, all good questions. The impact on local surgeries and the capacity and demand assumptions were part of the work. So I'm sorry if that's not reflected in there, but that absolutely is part of the work to work with those general practices, and as part of that managed list dispersal to work with those practices about asking them for expressions of interest for being able to take on patients, to allow them time to do that work around, looking at how they might manage the demand and being able to respond in a way that they think is sustainable. But I would say in terms of the sustainability piece, you've heard a lot earlier about the importance about primary care networks, and from Kate around the sort of future integrated neighbourhood teams. And I think a lot of GPs and practices would say that a small practice is unlikely to be sustainable as a single business entity in the long term. And that's why I think we're seeing the development of practices working together, practices starting to think about mergers or new business models about working at scale, which is where the primary care network idea is part of that, trying to work at scale to meet population needs, and the shared workforce through things like the additional roles, because the recruitment, retention and development of staff is much more difficult for small individual businesses to do these days. So I think part of that is coming through. In terms of your point about forecasting, we do an awful lot of work with general practice and with representatives to try to understand the sustainability of the current model. And as Kate was saying earlier, part of that work we're now doing with the GP Alliance. So we're asking the GP Alliance to work with us about looking at sustainable models of general practice and how we might forecast some of those challenges and intervene sooner. In relation to Winton, interestingly though, I don't think any of us called that. And in fact, speaking to other practices of that in the area, they didn't forecast it either because they thought that the business model should have been sustainable, but it wasn't. So yeah, that we did think that the model was going to be sustainable, which is why we supported the new arrangements from the previous owner taking that on. So that wasn't, that didn't come up in our forecasting at the time. Clearly, we can't forecast everything.
I'll just check I've got my head around all of that properly then. So in terms of the risks, because at the bottom of the risks there is nothing about the capacity of the surgeries those patients are going on to. It's about continuity of care and so on, those perceived risks. And that's because actually it was felt that that influx of potentially 2,000 odd patients for each one of those surgeries, they were well within their rights to be able to cope with that. That's correct.
We asked them, as I said, we'd asked them to do an assessment of their ability to take on that number of patients. So we asked them to assess the risk.
And then in terms of forecasting what's happening with other surgeries in the area, there's no cold, hard method you've developed yet for doing that. But in your opinion, the direction of travel is very much away from smaller GP surgeries and the merger into larger and larger surgeries. And that is something that that's just something we're going to need to account for when it comes to what is the health service going to look like in 5 years' time, in 10 years' time. You're going to have far fewer individual surgeries and a lot more of these big amalgamations.
I told you, and I'm trying to think of the years, but maybe if you went back 20 years, I think we had about 104, 105 practices in Dorset. We've now got 70. So I think that answers your question. But we don't. The mergers come about because of practices looking at the sustainability of their business model. So we're not encouraging people to merge. What we are encouraging is general practices to work together between practices, with their community pharmacies, with their community services and others, and with the voluntary sector. And that's what Kate said earlier about the importance of that integrated neighbourhood team working, because that's where you get more integrated care, but you also get a more sustainable model of joint working to meet the needs of your population.
This will be my final question, because I'm late to the party on Winton closing. My understanding, and this could be totally wrong then, because it's not something gleaned from papers this evening, it's horrible gossip, essentially, but was that the premises, when the regulations changed about the size of a consulting and treatment rooms and so forth, that premises no longer had enough rooms that could be classified as either consulting or treatment rooms for them to register enough patients for them to feel their business model was sustainable. And at that point, that's when the surgery was doomed. Now, is that just total claptrap, or is there any truth to that? Because I've definitely got some things wrong in my head this evening that you've explained well, and that might be another one you're about to do.
Okay, well, that one I have no intelligence to confirm that information.
Okay, thank you very much. I just wanted to pick up the point that Councillor Sam was just raised. Outside of the meeting, when we were looking at the agenda, I asked one of your NHS Dorset colleagues about whether this was a one-off and whether or not there were any other kind of warning signs of other practices on the horizon. And I think I was reassured actually that you've got indicators in place which allow you to intervene where you need to intervene and the degree to which you think you need to intervene. So I'm just hoping that I haven't got that completely wrong.
No, we have got indicators. I suppose I was just making the point that these are individual businesses. So we then have a dialogue with that practice or that primary care network area to say, we want to work with you to make your area more resilient. Are you aware of some of the factors that might be? We do a lot of triangulation of intelligence around that to try to inform that, but they are individual businesses. So we have to build that relationship around helping them to do their own forecasting as well and build those relationships with the other practices in the area. Because I suppose what I'm saying as well is you may have a practice that's at risk with resilience, but that can be made more sustainable if it's working with other practices and other providers in that local area.
Thank you. Right, with your permission then, I will move on to item 9 and the merger of the Adam Practice and Lifeboat Key Medical Centre. So over to you again.
Okay, thank you, Chair. So again, paper received by the committee, so I'll take that as read. And I was just going to again highlight a few key points, if I may, and then take any questions on this. So we've approved a proposed merger from 1st of October for Adam's Group Practice with Lifeboat Key in Poole. And I think we would see this as good news for the Poole Central area, because this is about some of the triangulation of the data in that area was highlighting that there was some risk to sustainability of models in that area, and that Lifeboat Key then approached us about their concerns. And through that network working, it led to discussions between Adam's Group Practice and Lifeboat Key about a shared future. So that's really what's behind that proposed merger. So we feel it's good news because it will make a more sustainable model of delivery for that Poole Central area. And I think it reflects the discussions that we've had tonight really about how small practices are finding it difficult to recruit, have a sustainable workforce model, and a sort of sustainable and resilient business model as well. The other good news is that the merger plans are to safeguard the future of Lifeboat Key. And those of you who haven't visited, it's a very modern general practice, and one in the NHS Laker we're very proud with our partners that the Lifeboat Key is a really high quality premises in the centre of Poole. So we absolutely didn't want to see that investment of public money into that facility to a closed practice. So we've had assurance from Adam's Group Practice working with Lifeboat Key that this will also maintain access to all of the sites in that area. There's 5 sites across Adam's Group and Lifeboat Key. So I think it links to the conversation earlier about improving access to care and sustainability of the model of care. And as part of this planned measure, again, we will be working with patients and key stakeholders locally on the engagement around this merger. And as I say, we're seeing it as a positive move forward around sustainability of the model of care in the Poole Central area.
Okay, thank you very much. Any questions, anyone? Are we happy then? We'll move on.
Thank you, Chair.
Right, it's going to move on to item 10, the Local Government Association Peer Challenge, and got Betty Butlin, Director of Adult Social Care, and Chris Mackenzie, I think both online to present the report. So over to you. Thank you.
Yeah, thank you, Chair, and sorry can't be with you in person tonight. I'm just going to put some context, and then Chris is going to talk through the report, and we'll take any questions at the end. So just to put some context, Bournemouth Christchurch Poole Council, we asked the Local Government Association, the LGA for short, to undertake an adult social care preparation for CQC Assurance Peer Challenge within the Directorate of Adult Social Care within the council. So I asked them to come in order to seek a few from them and how prepared we were from their perspective around adult social care and the new care quality CQC regulations that are now in place from April this year. And just to put further context, CQC assurance process came into effect from April 2023, and this is specifically for adult social care departments, and they will be working their way through councils, and they have already begun pilot assurance, CQC assurance processes within councils' adult social care directorates. So the peer channel, sorry, Chair, I've got a bit of a cold, is designed to help councils to work through to understand where they are, understand their position, and to support councils in understanding their position and where they are through a series of activities that they will undertake. So the peer challenge team arrived in BCP Council and worked with us. I think it was from the 6th to the 8th of June they were on site. There was a team of 7 of them. They came in, very experienced individuals from across the country that have really detailed experience and knowledge within that environment, the environment of adult social care. They conducted many interviews face to face. They saw, I think it was 152 individuals from a range of partners, some within the council, some within the health sector, some within the voluntary sector. They also met with key members, portfolio holder, and at the end of their time with us, they did a session on their last day, and the leader was present for that, as was the adult social care portfolio holder and our chief exec. So they conducted a very detailed piece of work in the time that they were with us. And we would like to thank the LGA for the work that they undertook and the time and effort that those individuals that were with us spent. They read something like 87 documents, and as I said, they met with a high number of individuals, and they spent, I think they told me it was around 200 or over 200 hours, the work that they undertook, which was the equivalent from their perspective of around 28 days with us. So we found it an invaluable piece of work. Their report you have as an appendice within the documents. The report is detailed, it's lengthy, it demonstrates our strengths, and it also highlights areas for further growth. So I'm just going to hand over now, if it's okay, and happy to take questions at the end, to my colleague Chris, who's going to go into a bit more detail with members in regards to this matter. Thank you, Chris.
Thanks, Betty. Good evening, everybody. So in terms of the report itself, I won't go into a huge amount of detail because you've got the report in front of you, and it sets out, I think, quite clearly, as Betty said, the strengths and the areas for consideration. What I will just explain is a little bit about how we will intend to use the report as part of our ongoing preparations for CQC assurance. The report that we've now received has led to the creation of an action plan, and one of the areas that we've sought to strengthen is in relation to our governance arrangements, making sure that we've got appropriate arrangements in place to support a programme of continuous improvement against not just the areas identified by the local government association, but also other service improvement activities and initiatives that we already have in place and that are underway. So that report and that action plan will now be monitored, the progress, through a adult social care performance and quality improvement executive board, which will be chaired by the council's chief executive, but also attended by the corporate director, the relevant directors, and also the portfolio holder for health and wellbeing as well. We've also, as part of our preparations, we've developed a self-assessment document. We intend to keep that as a live document that we will continuously review, update, and ensure is fit for purpose and ready to go when CQC come to undertake their inspections. The latest intelligence we have, and this is not formally confirmed, but is based on what we've been told by the region, is that we should get around 8 to 9 weeks notice of a CQC assurance visit, which will give us some time to prepare and get ourselves ready for that. But we have used the experience of going through the LGA peer challenge as a practice run for the CQC assurance visit as well. So getting the practical arrangements in place, making sure we're prepared for that, has also been part of the exercise as well. I'm not going to go through the report in any great detail because hopefully it's fairly clear, straightforward, and sets out the areas of strength and the key areas for consideration, and happy to take any questions or comments on the report from any member of the committee. Thank you.
Thank you very much indeed. Any questions, anybody? No? I can't see any hands, so that allows me to thank you very much indeed, though, for the report. That's really helpful and really encouraging, actually. In terms of the scrutiny of the content of it, again, if there are any aspects of the LGA peer challenge or indeed the impending CQC inspection that members want to ask, again, perhaps we could take the opportunity of the forward plan meeting that we've got coming up to highlight those and to decide what we're going to do with them. Other than that, you've no doubt got plenty of work to be doing in terms of preparation for the CQC. So thank you very much. Okay.
Chair,
sorry.
excuse me, Chair. May I just add one thing? Is that okay? Sorry, you probably can't see my hand. May I just add one thing to say that once when the documents have been through this meeting tonight, ONS, so we've shared and we've given a copy, provided a copy of the LGA peer review. I will let the LGA know tomorrow that it's been through ONS, and then the report that you have as an appendix within the document, the peer review document, that will then go to be published on the LGA website, so it will be open to the public for them to look at and to be aware that it's there. I will let them know that tomorrow. So just for noting as well, maybe. Thank you.
Very grateful for that. Thank you very much. Councillor Salmon, did you have a question? No. Okay, thank you very much. We'll move on then to item 11 on the agenda, which is the portfolio holders update, and I'm going to invite Councillor David Brown to give us a verbal update, please.
Thank you, Chair. I'll try and keep it brief, but since the last meeting over the last few months, not a few days go by really without having to sit on a different health or social care related board meeting, or my diary has been incredibly full over the summer with various visits and the number of boards and committees and governance boards, etc. is quite significant within the sort of adult social care and health area. So just a few brief sort of bullet points of updates on things since the last meeting, really. One particular point to note is the appointment of a new corporate director of wellbeing. So interviews were held. There were shortlisting interviews held a couple of weeks ago, and appointments been made. I think that's subject to sort of go through due process. And although it would normally come to council because of a wait for the sort of next full council meeting, there'll probably be a chief executive decision that will be reported to the next full council, and that will significantly help things, because having a corporate director for wellbeing will not only oversee adult social care and health parts of the council, but housing and community sections would move from operations over to under the new corporate director for wellbeing. So that will be happening over the coming weeks. And just updates of the sort of key things, particularly within adult social care, as mentioned, the LGA peer challenge and the CQC assurance review work that's just been referenced. So there's been a lot of work obviously going on within adult social care around that, and I'm pleased that we've got the Adult Social Care Performance and Quality Improvement Executive Board, which met a few weeks ago, which I attend and was referenced there, and that's to sort of look at the actions that are necessary to sort of build up towards the CQC assurance visit. So I've attended that, and it was incredibly informative, actually. That was probably one of the best meetings I've had in the last couple of months in my position, to sort of be able to really sort of dig into the sort of the operations and the numbers and the sort of things that are going on within adult social care. So that was really useful meeting. Other projects that are progressing, the opportunities review project is progressing. There's a co-production meeting next week around that big project, and I know that's been talked about, I think probably the last meeting as well, about coming to the Overview and Scrutiny Committee to look at that, the opportunities review. Probably most of the meetings have around adult social care budget monitoring and preparation of the 2024 budget. As you can well imagine, there's been many meetings sort of discussing budgets and the budget pressures within the current year and the savings required in the next financial year. Those are all coming. We've got a very intensive 2 days next week as a whole cabinet with the corporate management board too, because it's one thing to look at budgets within each sort of operational area, but actually we need to sort of bring everything together so that we can start to sort of prioritise areas within the budget. So there's 2 intensive days for all the cabinet corporate management board next Monday and Tuesday to really work through the detail of the sort of budget pressures that we've got and how we're going to cope with those. Lots of work around the carers strategy, which was obviously approved earlier in the year, and there's a carers strategy implementation governance board, and I also attended. There's a carers forum and a Pan Dorset carers steering group, so there's a lot of ongoing work within the sort of carers realm. Learning Disability Partnership Board met last week, had a big sort of workshop around progressing the big plan. The current big plan for around learning disabilities runs until 2024, but they're now reviewing for a new big plan to start to take over from that. So that was a really useful day last week, co-producing it with people from Paul First Forum and various different groups. The Dorset and BCP Safeguarding Adults Board is also due to meet again this week to sort of progress work on safeguarding, and I've also had some meetings with Tricuro as well to understand their operations, and we'll be doing some visits over the coming weeks with them. So obviously, for those who aren't aware, Tricuro is the council's local authority trading company that delivers a lot of our sort of residential and care services. Within the health area, there's been meetings of the Dorset Joint Public Health Board, which I now chair, and that met in July, and the Health and Wellbeing Board also met in July, and I now chair that as well as obviously work with the Integrated Care System and the Integrated Care Partnership, which is going on, and preparations around CQC are also due to do an assessment of the Integrated Care System. I think there's meetings in October coming up for that. So as well as the CQC looking at our adult social care services, they're also now looking at the Integrated Care System across Dorset. So, and that's coming first. So we've got meetings during October to meet with CQC on that. Other than that, that's really the sort of areas that I've been working on. Always happy to talk to people about various committees or groups that are meeting.
Okay, thank you. Any questions? Councillor Debnam.
Thank you, Chairman. Yes, I'd like to agree with David. It's a really heavy duty portfolio. I just wanted to point out, Chairman, that going back to the previous item that we had, the peer team suggested that BCP Council consider the risks of change fatigue and of staff well-being. And I'd like to ask David if he's taken that on board. I'm sure he has, but I'd like reassurance on.
Yeah, thanks for that. I have obviously picked that up during the LGA visit and in the report, and it's one of those, you know, and I probably was remiss to say actually over the last few months I've been really impressed with all the teams I've met, particularly in adult social care, and the social workers I've met in various sort of meetings and visits, that their dedication and the positivity in the face of all the sort of, particularly the budget difficulties and the difficulties the council has. So there's an immensely good and experienced workforce. Been really impressed with their dedication, and you know, it comes through in the peer review report that they were as well. And it is a concern, you know, that there's growing pressure and growing demand on services, and I think that's the real difficult thing. That it's hard enough to look at budget savings and having to reconfigure ways of working to do them more effectively and more efficiently. It's hard enough at the best of times, but obviously when there's the prospect of CQC coming in to check what we're doing, that sort of trying to get that balance right in terms of we don't want to be making changes or you know, making savings or cuts even just at the point that we're going to be assessed on those services. You know, we've got to be quite sort of careful and delicate to make sure that we're well prepared for the CQC visits and to get the best outcome we can from that. But we've got these big budget pressures coming up as well. Trying to get that balance right is really difficult, and it is a concern about the sort of well-being of the staff, you know, and the pressure that they're under. And something I've picked up as well is particularly around pay and reward, and I really just hope that the whole pay and reward project sort of moves forward now with the unions and reaches a conclusion, because there are difficulties with adult social care. I mean, I think interim measures were put into children's social care around sort of social workers sort of pay and reward to sort of retain them there. I think there's only so long you can go on with the discrepancy between children's social care and adult social care. You know, we need to resolve a lot of those issues and move the pay and reward system through and get that sorted. Otherwise, you know, you are sort of raising the risk within those areas. So.
Okay, any other questions? Councillor Salmon.
So I kept quiet during the last two items because my questions are pretty much always going to be the same. It's all data stuff, and really I think both of everything we're looking at is being hamstrung by how data blind we are as BCP Council, and then I think also as a not only looking at what the council do from an adult health and social care point of view, but actually the wider operation of all of the organisations that make up the ICB. And I know something that Tricia Miller, who is the chief exec of the ICB, is that right? That's, yeah. That she has spoke about having an ICB-wide data strategy. And I think that work would sit within the DICE, which I think would be Heather Case. And I'm just curious, are those conversations happening with those individuals, potentially with the relevant officers within BCP? I forget who it is within BCP, but it's someone, isn't there, in charge of data and whatnot. But that seems like a piece of work that urgently needs to progress and almost should take priority above everything else, because it feels like we are flying blind in terms of knowing what's going on with the services in the area. Because I know since we last met, there was an 18-year-old gentleman who I think passed away waiting for 111 to phone him back. Just a horrible, horrible tragedy. And I'm not aware of a mechanism by which we would have been aware of actually those incredibly long wait times, because we don't have that wide pre-analytic overview at the moment. Everything we're scrutinising is being scrutinised at a very micro level almost. We don't have that whole systems overview, and it sounds like there is the political will there in some parts for that to happen. But I'd just like to know actually where are we in practical terms on that? Next time we sit down, are we going to have the lovely all-seeing dashboards that I'd like to see, or is that 2 years away? You know, or is that something that we've not even started looking at how long it would take to implement?
Thank you for the question. I would endeavour to answer to the best of my ability on that. I must admit, the last couple of months, a lot of my focus has been on adult social care, and we have a lot of financial and budget data and sort of detail about sort of clients and assessments, etc., within that area, and some really sort of useful insight there. On the health side, it's probably a better question for either the chair of the integrated care board. I must admit, I'm not on the integrated care board as the portfolio holder. I sit on the integrated care partnership with our corporate director of wellbeing, or interim corporate director of wellbeing at the moment. The integrated care board is the leader, and the chief executive sit on that. I've not actually yet sat on a meeting. There was a Integrated Care Partnership Board meeting, but due to an oversight I wasn't invited, so there's due to be one coming up. So I've met a couple of the people, but I haven't actually attended a board meeting, a partnership meeting, and attended all those. So I can't, to be honest, I can't answer that question at the moment. But yeah, I'm sure probably a more appropriate question for somebody who's under the chair of the Integrated Care Board.
Yeah, sorry, I probably asked it in a very inelegant way, and I recognise, God, you've been doing this for months, and there's a lot to get to grips with. Just out of curiosity, because from my point of view, it feels like we are trying to drive a car where the windows have been painted over, and we cannot see what's going on with the quality of data we're being presented with. But no matter what, anybody who works in the NHS can tell you, at this point, the car has driven over a cliff. We are in free fall. And even once we've got a handle on what the situation is, I don't think any of us in this room are in positions of power and decision making where we can address those issues. I think a lot of the things, so when we were talking about dental services at the last one, conclusion was very clear. Actually, dental services are a mess because of a dental contract. Now, that is something that is outside of our gift as the local authority or any of the organisations that make up the ICB to address. That's something that actually needs buy-in from Parliament. That is something that needs legislative changes. What's the kind of buy-in we have and our relationship with the MPs for the area? Are they paying attention to what's going on? I have no idea what they do, I don't know if Tobias is just going to rock up and say maybe the Taliban could run the dental services, but in practical terms, are they paying attention to what's going on and aware of kind of how bad things are in adult health and social care? Well, I say how bad, I know we're not definite, but I think when we start looking at the nitty gritty, it's going to be a grim picture, and it's not something that any of us in this room are going to be able to address without that change from national government. And I just want to know what's your feeling on that. Are they talking to you? Is what's his name, Tobias, or who's the other one, Connor, drop you an email every now and again going, hey David, what are you reckoning? I don't know.
I suspect when they want to discuss or consult on those issues, I'm not the top of their list. I don't hear from them, frankly. I think I don't know if I'd characterise the situation the same way that you do. I suppose what I would say, I'm at the Liberal Democrat conference all this week. I've come away tonight for tonight's meeting. I'll be going back there later, and attended all sorts of meetings around social care, housing, the health system, and it's. I don't want to make a political point. It's interesting the number of areas people talk about a crisis, the cost of living crisis, the sort of housing crisis, the sort of crisis in the health service. It seems like lots of our sort of public sector are having a crisis at the moment, and it's well above my pay grade to try and sort out those crises. But I think for me, the integrated care system, it's in its sort of infancy, really. It's finding its feet, but does hold out a great prospect for, if done the right way, for actually really bringing people together and moving the NHS system from being a sort of health treatment service to being a preventative service, and actually really getting in early and trying to have more of a long-term view of things. It's really difficult because politicians, especially nationally, tend to have a short-term view, up to the next election. So we've got to cut this waiting list, we've got to treat this many people, etc., etc. We need to get ahead of that, and we need to have a sort of 20-year view that we need to be working across the system. Health is not just about the NHS. Health is about housing. Health is about the care system. Health is about our open spaces. Health is about air pollution. It's about all sorts of things, right, cross-cutting across government. And I'd love to think that, the government in the future, whatever colour it is, actually starts to think long-term around these issues and planning for the next 10, 20, 30 years of the sort of public health and health of the nation, really, to sort of move that agenda forward. I think the integrated care system offers us a system to attempt to do that and have real local input for our local community. So I think there's reasons for optimism, but yeah, that's probably all I've got to say on it.
Councillor Dettman.
Yes, thank you, Chairman. I'd like to totally agree with Councillor Salmon, although I would point out there are other MPs available in this area, not just the two you mentioned. And I totally agree, it is a central government issue, very much more than local. And they do need to be made aware, Chairman, and I think that is the point of this committee, that what we do should be published, does go to Cabinet. And I don't particularly share the portfolio holders' feelings that there's reason for optimism.
I can see Councillor Brown not wanting to be drawn on that. Are there any other questions? Councillor Brown.
You talked about the fact that you chair the Health and Wellbeing Board. I think it would be helpful if this committee had greater sight of the Health and Wellbeing Board. I know it's public, but it's an integral part of what we do in terms of the health system. And I just wondered how we could bring that more into this committee. I mean, perhaps at the most basic level, it's the minutes being admitted to the papers for this committee or something. I don't know, or how could it be brought more in?
Yeah,
People want it to be.
No, it's a good point, and it's you know, I've only attended one in July, which I then became chair of. And I would say that the papers for the Health and Wellbeing Board are available on Modern Gov, so members are able to sort of see those in advance of the meeting. They're aware when the meetings are coming up, what reports are going to that, and it's a public meeting as well. I think it's a good point actually. If as an overview and scrutiny committee, you want to have more oversight of what's been delivered by the Health and Wellbeing Board, and I think I probably took my first meeting to sort of test the water and see how it was operating and what it's aiming to deliver. And I think there was a question mark about making sure that within the new integrated care system that we get the most from what the Health and Wellbeing Board does, and make sure that it's clear what its role is. Yeah, I'll have to think about it.
Thank you. Any more questions? Okay. Thank you, Councillor Brown. So item 12, forward plan. The forward plan is outlined in the papers that you have before you, and you hopefully will have received the email saying that the meeting to discuss the forward plan is on the Monday, the 2nd of October. My apologies for the fact we couldn't get it earlier, but it's next Monday. What I've asked Democratic Services if it's possible to do is to either use this document or some other document to try and ensure that we capture as much of the actions that we think we want to look at as a committee as we can. So rather than looking at actions arising from the minutes or whatever it is, and maybe the forward plan document is as good a document as any to do that. But what I'm trying to do is to capture anything that we want to look at, even if it's kind of down the track a little bit. But what my plan is for the forward plan meeting on the 2nd is to work through the items that are on that list and to firstly look at the time scale and the issues that are coming up, and then whether things need to be added or taken off, and just to have a bit of a review about things that colleagues would see as being priorities that we need to look at. So I hope that makes some kind of sense. Are there any questions about the forward plan or comments about the forward plan? Councillor Farr.
Thank you, Chairman. As I mentioned earlier, I met with Sue Waugh from Prima Life. She was quite keen to come along and come along to the meeting and talk a bit about Prima Life and take some questions. I just would like that to be included. Thank you.
All contributions would be welcome. We just need to look at the issues that are coming up in a very open and frank way, I think. So thank you for the offer. Councillor Salmon.
So I obviously you guys probably know what I'm going to say, and it's about the pre-analytic vision I've got here, and I'm a little uncomfortable with us jumping into dental provision in November. I would much rather we were starting with taking a wider view of the health of the organisation, the health and the effectiveness and the efficiency and the performance of the organisations that make up the ICB, and actually of BCP Council itself in terms of meeting its statutory requirements. And I think that needs to happen first before we can then decide to do a dive into things like how we do it, what's our provision for dental care, for suicide, for rough sleepers and all of that. We need that wider pre-analytic vision first. And I actually, if there is our role is meant to be that of a critical friend, and if there was an area where I feel it would be useful for us to be a critical friend, kind of going, oh, you could do it like this, you should do it like this, and all of that. Oh, that's a good idea. Maybe that won't work if you consider this. Actually, it is in building that pre-analytic vision, which doesn't exist yet. And I think that's where we should be starting off before we get as hyper focused as we will be if we go with this forward plan as is. I think it's a shame we couldn't have the forward planning meeting to discuss this after the first session. I think there was an issue with officer time, which was a real shame, because I think that would have been a valuable session to have. But I think we need to do that first, and almost as a starting point, we should look at the materials that go to the ICB board meetings as is, because those materials are a very good starting point. But again, they do suffer from being PDF reports where data goes to die. And what we need is not PDF reports. We need to be able to slice and dice our data. We need to be able to drill down into things. We need to be able to say, oh, a resident in my ward who's complaining about getting access to dental services, I can see this is the number of dental surgeries for accepting new patients, because bless Health Watch, at our last meeting, they had to find that out by literally phoning round all of the dental practices on the, I forget which website it is, but where you will be told to go to register for a new dentist. You phone them all up that say they're accepting new patients, and then you find out, oh no, they're not, because that information is not being kept up to date. All of those things need to happen first. You know, that pre-analytic vision needs to be in place, and that's the creation of that pre-analytic vision, I think, is what we need to be scrutinising first. I hope I've made myself clear, because I'm not on it at all this week.
Yeah, I'm pretty clear about that, Councillor Simon. We'll try and pick up that at the meeting next week. We don't have to we don't have to take dental services in a timescale that's laid down. It's up to you to determine what the priorities are, what we need to do first. So let's have a bit of an in-depth discussion about that next week. Okay. So item 13 on the agenda is future meeting dates. There are a schedule of dates for 23-24, and the next meeting is on the 27th of November. So if there's nothing else, thank you everybody for your input and questions and contributions, and we'll see you in due course. Thank you very much indeed.